Hello, friends. So I'll be talking on this topic, severe dengue illness. Can we do something different? So this talk was given in one of the local meets that we had at our hospital. So now it's a dengue season, so we are seeing a lot of dengue cases, and it is prudent that we tend to understand what is the new science that is evolving in dengue. So the topics that I would be covering is first to try and understand how dengue causing life-threatening situation or a dengue sepsis, how is it different to bacterial sepsis? And we'll try to understand about the dengue pathophysiology. So that's the dengue virus, that's how it looks. We'll look into the clinical spectrum of the disease. And the fourth aspect is most important to try to look into warning signs and how the liver gets affected in dengue. And the way we approach clinically with regards to clinical assessment and treatment principles, and what is it that we have in store for the future. So what are the future directions that we would have? And it's good to dwell about the current understanding of the dengue vaccine that is available. And it is quite, when I was preparing for this topic, it was quite surprising for me as to why India, which has a huge burden of dengue, not invested into getting this dengue vaccine on board. So this is something that has perplexed me and bewildered me. So it is a question that we need to ask oneself as a healthcare society as to why, as a country, we have not invested in getting this dengue vaccine into our country, which holds good promise at this point of time. And summary. So these are the topics that we tend to cover. So this is just a schematic representation as to how the whole sepsis conundrum happens. So here you have pathogen associated molecular proteins, and then you have this damage associated molecular proteins. So which leads to activation of these macrophages, and they release a lot of these cytokines, as you most of the listeners would be aware. So tumor necrosis factor alpha is one of the sort of a uh, inflammatory marker that induces lot of pathognomonic changes that happens in sepsis, like typically the vascular leakage. And then you have this interleukin 1 beta also, which gets released, which causes adhesion. So basically the whole blood vessels become sticky and there is adhesion of all these leukocytes into the vascular endothelium, causing disruption of the endothelial integrity and leakage of the vasculature and loss of fluids. And then you have these other interleukins that get generated, 16, interleukin 18, interleukin 6, so on and so forth. And each interleukin has a specific predilection to certain organs. So as you see, some of them have predilection to the liver, some of them to the brain, which cause a lot of manifestations leading to multi-organ dysfunction. So this is just a schematic representation as to what really happens at cellular level. So the essence is that a lot of cytokines are released, a lot of interleukins are released. So they cause a lot of vascular leakage and adhesion of the vascular endothelium to all the leukocytes and certain interleukins, which have deleterious effects on certain organs. So if you remember that, that should be good enough. So, but there are certain distinct differences between bacterial infection and viral infection. So in this schematic representation, you see the bacterial infections lead to the production of interleukin 1 beta. It leads to production of interleukin 6, which causes production of CRP. So this is the pathway. So that's fine. One thing that the listeners should pay attention is in bacterial infection, it is the CRP which tends to rise. But I'm sure most of you now are well conversed with the viral infections, more so in the face of COVID. In viral infections, there is production of interleukin 18, and which leads to increased production of ferritin. So many of you are aware that in viral infections, ferritin is a sort of an inflammatory marker which tends to go up in most of the viral, and you have seen this. And even the HLH workup we sort of do in post-viral sequelae, ferritin is one of the markers. And even in COVID, we used to do ferritin. And we have seen that raised ferritin was a marker of severity of viral infection. So this is sort of a distinct difference that in bacterial infection it's the CRP which rises. In the viral infections, it is the ferritin that goes up. So this is one of the important difference that remains between bacterial and viral infections. So this is a good article that dwells upon what typically happens at cellular levels in viral infections. So what really this emphasizes is in viral infections, the pathognomonic change that happens is lot of paracellular leak and the transcellular leakage that happens. So basically, your whole endothelial integrity. So if you look at this as a vessels, and this is the endothelial cell layer. So there is lot of leakages that happen because the endothelial integrity is lost, and there's a lot of leakage of water content from the blood vessels that typically happens, and it happens in a pronounced way in the viral sepsis. So this is the close-up of the vascule. So this is the endothelial cells, and the pink one is the vasculature. So, and there are these bridges as you see, and this is called adherence junction. So as the name suggests, adherence junction maintains the vascular integrity by bridging the endothelial cells. As you see, these two are the endothelial cells. They are bridged in a very adherent way by these adherence junctions, and this is called the tight junctions and the glycocalyx. So these are the three elements which tend to maintain the integrity of the endothelial cells and its integrity: glycocalyx, adherence junction, and the tight junctions. In the adherence junction, this dumbbell-shaped sort of a molecule that you see is labeled as vascular endothelial cathedral. And these are the ones which sort of bridge the endothelial cells, and their function is determined by and it is influenced by the calcium. So the viability or the function of these vascular endothelial cathedral is determined by the calcium, and the cellular integrity is maintained by some of these protein elements like P1T, 120, catenin, and actin. So they form the exoskeleton or the framework that tends to maintain the integrity of the endothelial cells. So this is at a very cellular level what happens. Why are we interested in knowing this? Because dengue has a bearing on disrupting these tight junctions, adherence junctions, and thus as endothelial integrity, and that is why we are interested in these structures. So what happens in dengue? So in dengue, this vascular endothelial growth factor receptor gets activated, and it produces vascular endothelial growth factor, and this leads to disruption of this vascular endothelial cathedral. As you see, the bridges are broken down here, and this sphingosine 1 phosphate leads to activation of certain proteins which maintain the integrity of these endothelial cells. And that also leads to disruption of this vascular endothelial cathedral. So what this has led is, this has led to the development of certain molecules like SLIT2N protein, which is shown to maintain the integrity of this vascular endothelial cathedral and reduce the intracellular and paracellular leakage of the fluid. So this is at a cellular level what dengue does. So that it causes disruption of this vascular endothelial cathedral, which is dumbbell-shaped bridges, which maintain the integrity of the endothelial cells. And this has led to the development of certain proteins which adhere to this vascular endothelial cathedral and maintain the integrity and not allowing the disruption. So that is where the new science is evolving. And these molecules are shown to have some survival benefit in the rat models, and it creates some potential new avenue for the treatment of viral sepsis. So this injection SLIT2N, which is a protein, which is known to maintain the integrity of this vascular endothelial integrity, cathedral. So if you see, so this is the mice which are infected with dengue. So as you see, there is a lot of inflammatory exudates within the alveoli. After the injection SLIT2N protein is given, you can see there is a good integrity that is maintained, and the extravasation of the inflammatory exudate has not happened. So this is an experimental study in the animals that they have shown. And we understand, so in dengue, the or like in any other infection, so there are different phases. There is immune activation, and then there is a immune suppression, and then there is a progression of organ dysfunction that happens in this sort of a phase, immune suppression, which ultimately leads to death. So these are the different phases which typically occurs in any of the infections. So let's look into some of the key differences in with bacterial and viral infections. So in dengue, as you know, the total count in bacterial infection will be high, but in viral it can be normal or low. And prodrome typically you don't see in bacterial; it is more likely in viral. And acute MODS is very unlikely in bacterial, because in bacterial infection there is a some amount of time that it takes for the organ dysfunction to set in. But in viral, we have seen that organ dysfunction sets in very early, and you would typically see there will be a history of few days and multiple organs would be affected. And serocytosis, like a lot of effusions accumulating everywhere, that is typically seen in viral and not in bacterial. And as I said, CRP is a good marker for bacterial. CRP goes up significantly high in bacterial, not so much in viral. And ferritin is a marker of viral. So viral ferritin typically goes up and not in bacterial. And lipopolysaccharide binding protein goes up typically in bacterial. And neutrophil lipocalin also goes up more in bacterial and not in viral. So these are some of the reference sort of differences between the bacterial and viral. But for all the listeners, the practical point to be noted is CRP goes up more in bacterial, ferritin goes up more in viral, and the other sort of a elements that you see are more for academic purpose. That some are more in bacteria and some are more in viral. So now again coming back to dengue. So dengue is a flavivirida. 2.5 billion population worldwide is at a risk, and annual incidence of dengue is 50 million. And again to look back, so this is the dengue virus. So this dengue virus typically produces tumor necrosis factor alpha, in which we saw it creates disruption of the vascular endothelial cathedral and causes the vascular leakage. And along with this, dengue virus leads to reduction of activated protein C. And reduction of activated protein C is what causes the hemorrhagic manifestations. And dengue causes activation of these dendritic cells, and these dendritic cells get activated and they produce increasing levels of gelatinolytic matrix metalloproteinases. So this is the molecule or the protein that these dendritic cells produce. As the name sounds, it's gelatinolytic matrix metalloproteinases. So it lyses. So that's why it leads to disruption of this vascular endothelial cathedral and leads to paravascular and intravascular leakage of the fluid. So this is at a cellular levels what dengue does. And this is just another schematic representation. So as soon as the dengue mosquito bites, so these dendritic cells and macrophages get affected by the dengue virus. The yellow one is the virus, and then it expresses these signals, which leads to trafficking of these cells into lymph nodes, and all these cells get cellular cytotoxicity happens, and a lot of inflammatory cytokines tend to get released. So this is just another schematic representation as to what dengue does to different cells. Mainly it affects dendritic cells and the macrophages, which leads to recruitment of other cells, leading to cytokine storm and the interleukin production that typically happens. So now looking at the clinical spectrum, so dengue is broadly classified into three clinical presentations. One is mild dengue fever. Predominantly, we know around 90% may have mild dengue fever and it will settle. But small percentage of patients develop this dengue hemorrhagic fever. The more disastrous or catastrophic presentation would be dengue shock syndrome, which as intensivists we tend to see more in ICU. So this forms a small percentage, but can create havoc to someone's life. And they have done studies in animals, so rat models. Predominantly, dengue studies have been done in rat models, and dengue virus is infected into the rat. So basically, they have tried injecting this fibrin-derived peptide, so which was codenamed as FX06 twice a day. Uh, Within 3 days after the dengue virus was injected into the mice. And basically, this fibrin derived peptide binds to this vascular endothelial cathedral and maintains the integrity of those endothelial cells. And this was shown to reduce lung and interstitial capillary leak within the. So we saw slipped N protein was another molecule that was used in rat models, which maintained the endothelial integrity. And this was a fibrin derived peptide, which was used twice daily in the rats, which is known to bind to the vascular endothelial cathedral and maintain the integrity of these endothelial cells. And it was shown to reduce lung and interstitial capillary leak, and it showed improved survival in rats. So this is something which is evolving in dengue, and very soon we may have these injection trials possibly happening in humans also. So in dengue, what typically happens is you have first 3 days of illness after the dengue infection, where they will manifest with temperature. And then during that phase, they tend to have a bit of a dehydration, and hematocrit tends to come down, and there is increase in the viral load in the first 3 days. After 3 days, 4 to 6 days is when temperature tends to settle. I'm sure many of you would see that this is the phase which is more alarming when they come to hospital, that they may not necessarily have high grade fever, but they may manifest with some petechiae or some bleeding manifestations. And this is the phase where we see in ICU or in the ward where hematocrit would have risen. So it would have gone up to more than 45. And this is the time where the serology comes positive. You do IgM, it comes positive, or any other test that you would see would come positive. Then you have this later phase, which is post 6 days, where the temperature would settle. If patient improves, there is a reabsorption, and sometimes they develop serositis in this phase, and then they get better. And if patients are getting better, platelets will start improving in the lab, and the IgM and IgG titers also tends to go up and then plateau. So this is in a someone where dengue resolves by itself and they start improving. So this is what we would like to see, and this is the general progression of the dengue disease. But during this phase, there are certain warning signs that every clinician should bear in mind. So the warning signs is any person who has active bleeding, so be it petechiae or be it oral bleeds or any bleeding from anywhere is a warning sign. Or someone with a very high hematocrit PCV of more than 45 is an alarm, which means they have lost because we have spoken so much about pathogenesis or pathophysiology, where there's a lot of paracellular or transcellular leakage of fluid that has happened. So there would be intravascularly volume depletion is quite significant, which is reflected with PCV more than 45, and increase in the liver enzymes in thousands. That could be life threatening. So this is something which every clinician should pay attention to. Or someone where lactate is going up. So if someone comes to ICU and you've done an ABG which shows lactate of more than 2, it tells you that there is a microcirculation deficit that has happened and perfusion issues have set in. And altered sensorium. Someone with encephalopathy carries a poor prognosis. So these are some of the broader sort of a warning signs that one should look into. And hemodynamic assessment, so just categorized into three sort of broad categories. So blood pressure in stable dengue will be normal. So in shock, it can be normal systolic blood pressure, but diastolic pressure may be high, and the pulse pressure tends to narrow. In prolonged shock, the blood pressure can become undetectable, and this may be very disastrous sort of a situation. And heart rate in stable, it will be normal. In dengue shock, when we say shock, not necessarily blood pressure is something that you would look at being hypotensive. Even systolic blood pressure may be normal, but the heart rate and the lactate may be going up, which may also tell you there is a microcirculatory shock. So heart rate going up, and in prolonged shock, it will be severe increase in the heart rate. Respiratory rate will be normal in stable. It goes up in shock, and they become very tachypneic in prolonged shock. Urine output is normal in stable, it reduces in shock and become oliguric in severe. Conscious level is normal, and they become restless in prolonged shock. Or capillary refill will be brisk in normal, more than 2 seconds in shock, and very prolonged in prolonged shock. Extremities are warm and stable, cool in shock, and cold and clammy. And pulse volume is good volume, weak, thready, or feeble and absent in prolonged. So these are quite intuitive, but it is important to recognize these signs: blood pressure, heart rate, respiratory rate, urine output, conscious level, and capillary filling, and the pulse volume extremities. Although they all appear very simple and intuitive, but very often I have seen that in the ward, seldom many of these signs can be missed, and they come to ICU in a very catastrophic situation. So these slides are put forth to dawn upon the importance of meticulous observations on these signs, because these are all simple, but any signs we miss out, then the next sort of a situation would be a life-threatening situation. So it's very important for any clinician dealing with dengue to keep a close vigil on all the simple, basic, vital parameters, which is of paramount importance. So the clinical features, so if someone comes with a jaundice like this, so then it is a poor prognostic sign. So the jaundice is generally associated with dengue shock syndrome and may be associated with non-survival, and generally it is associated with lot of bleeding manifestations. So someone comes with jaundice is a poor prognostic sign, and an imbalance between coagulation profile and fibrinolysis is a very poor prognostic sign. And it is shown that 17.6 to 20.4% of the dengue patients will have hepatomegaly. So this has come from the Indian study. And these patients can also have a tender liver. So that is something one needs to uh, bear in mind. So liver is an important organ which tends to get affected in dengue very early on, and it is important to look at the liver parameters as an indicator of severity. So the dengue can, as a virus, can directly affect the liver, or there can be dysregulated immune response to the liver. And most dengues will have mild elevation in AST, ALT, and this can lead to severe injury in some cases or fulminant hepatic. We have seen fulminant hepatic failure in our ICU few times, so it's not uncommon to see fulminant hepatic failure in dengue. And 60 to 80% of the dengue will have elevation in AST/ALT. In fact, we have done our study in our own ICU and published, which I'll show you soon, where 96% of the dengue who come to ICU have increased in the AST/ALT. And increase in AST is more than increase in ALT, but the AST gets corrected much faster. The AST normalizes much faster because AST has a shorter half-life of 12.5 to 22 hours, and ALT has a longer half-life of 32 to 43. That's why AST tends to normalize much early on. And AST/ALT can increase up to day 9, then they plateau and it starts reducing by 2 to 3 weeks. And at a hepatocyte level, the dengue antigen can cause a lot of these acidophilic bodies, and it can cause necrosis within the cells, and it can cause sort of a fatty deposits within the hepatocytes. And there can be portal inflammation, and there can be Kupffer cell hyperplasia. So all these changes can typically happen in the liver. So dengue can produce some hepatic cells necrosis, some fatty infiltration, and portal inflammation and Kupffer cell hyperplasia. So these are some of the changes that dengue can create within the liver. So it has a predilection to affecting the liver, and this is something one should bear in mind. So these are some of the studies which have looked at the dengue affecting the liver. So as you see, 86 to 96% is the is the prevalence of liver getting affected with raised enzymes. So even in our study, we saw 96% of them had transaminitis, raised AST/ALT, and 45 to 97% will have raised ALT, 86 to 96 will have raised AST, and 1.7 to 48% can have high bilirubin in dengue. And more than 10-fold rise in AST/ALT is found in 1 to 11.1%. So this is the statistics of all around 10 studies that I've shown, and I'll show you the data of our study. In our study, around 8%, I think, had a AST/ALT more than 10-fold rise. So this is the study we have published from our own unit recently. So we did a study of 80 dengue patients, and we saw transaminitis rise in AST/ALT to be present in 96.2%. And grade 1, which is less than 3 times rise in AST/ALT as per WHO, was 21.2%. Grade 2 is 3 to 5 times rise in AST/ALT, was found in 30%. Grade 3 is 5 to 20 times rise in the transaminases, so 36.2%. And grade 4, the previous study I said 1 to 11%. In our study, grade 4, which is more than 20 times rise in transaminases, was found in 8%. So this is our own study. So typically, the point that we are trying to emphasize is dengue almost always affects liver, especially in sick dengues who come to ICU. Now the question is whether affecting liver has a bearing on outcome. Yes, it does have an outcome. That's why we have to look into the studies. So what about liver failure in dengue? Liver failure, if you look at all this world data, it can occur in 0.31 to 4.44% of them can undergo fulminant hepatic failure. And even we have seen in our ICU 2 to 3 patients who have gone into liver failure and died. And the mortality when they go to liver failure ranges from 20 to 100% from these 4 studies that you can decide. So these are some other studies which have looked into the transaminase raise. So this is a study from Brazil. As you said, grade A is normal, grade B is increased ALT or ALT, grade C is increased in aminotransferases 3 times, and grade D is 10 times increase. But WHO grading is what we have followed in our study. So this was a study which came from Pakistan to see whether a raise in the transaminases had any effect on the outcome. As you see, mild to moderate hepatitis, and they looked at 436 patients with mild to moderate hepatitis and 81 with severe hepatitis. Here they found no difference with regards to death in mild or severe hepatitis, but ICU length of stay was prolonged in severe hepatitis. But this was another good study, which looked at 60 patients with mild to moderate hepatitis and 22 with severe. And as you see, death was more in patients who had severe hepatitis. This is fairly intuitive for us to reconcile to that more severe the hepatitis, more would be the risk of death, and that's what was shown. And even the ICU length of stay was more in patients with severe hepatitis. So these are the studies that we have. So now we look into the different stages which we have already looked into. So this is another classification, dengue hemorrhagic fever, grade 1, where you have duration of fever more than 2 days and less than 7 duration of fever 2 days to 7 days, where platelet is less than 1 lakh, plasma leakage. So what is relevant to ICU is grade 2, grade 3, and grade 4. Grade 2, you have spontaneous bleeding. Grade 3, you have hypotension for it, and grade 4, you may have undetectable pulse. So what we typically see in ICU would fall somewhere between grade 2 to grade 4. Grade 1, possibly all the OPD or the ward is what someone would see. So I request the listeners to pay attention to this slide, which is so important and which appears so simple, but we often see this sort of a fluid resuscitation or the treatment is seldom undertaken in severe dengue. In fact, recently we have seen a very sick dengue who came to ICU and died because the resuscitation possibly was not very adequate that happens in the wards. So it is very important that every clinician pays attention to these WHO algorithms that are present, that fluid resuscitation remains the key to saving a life in dengue. If we do not resuscitate them well, if we do not pick up the early warning signs, then patients can very easily slip into multi-organ dysfunction and they die. And no matter what efforts we put in ICU, we may not be able to save. So it's extremely important that people have in mind there are certain goals that you need to follow while resuscitating dengue. So if you see this is a simple algorithm, and this is a WHO endorsed algorithms which are present everywhere, but this is seldom followed by many clinicians when they're treating dengue in the wards. So I have to say this because we have seen patients coming to ICU very sick, being under resuscitated in the ward, because the type of resuscitation you have to do is a very high volume resuscitation. So when you find a sick dengue with warning signs with a high PCV, the sort of resuscitation should start with 5 to 10 ml per kg per hour. So what does that mean? If I'm telling 10 ml per kg, if it is a 60 kg, I have to give at 600 ml per hour. If it is 5 ml per kg for a 60 kgs, it means I have to give 300 ml per hour. But very often you would see in the ward the PCV, someone sitting at 45 PCV, doctors giving 150 ml per hour, 200 ml per hour. It is not enough. You have to give at 500 to 1000 ml per hour in some cases, because especially obese patients, you have to calculate per kg. If it's 100 kg person, 100 to 10 is I have to give 1000 ml per hour. Please remember this. This is very, very important because you start at this, then you have to check the hematocrit. And if hematocrit is improving, then you see the left side, then you have to reduce, you have to give at 5 to 7 ml per kg for 1 to 2 hours. Again, check hematocrit. If it's improving, then you bring it down to 3 to 5 ml. 5 ml is 300 ml per hour for 2 to 4 hours. So you have to keep giving it until you see the hematocrit and your warning signs have improved. And then you have to decide on tapering it down and finally stopping at 48 hours, which means the resuscitation has to be ongoing with follow-up of hematocrit, follow-up of all your clinical trends. Okay. And if you see hematocrit is the guide. So if there is no improvement, you have to again check hematocrit and then you have to increase. So there is no business that patient comes to ICU and I'm told that physician is giving or a doctor is giving fluids at 200 ml, 250 ml. It is still less because you have to give at 500 ml, 600 ml, 800 ml. It is 10 ml per kg. If they are not improved, hematocrit has gone up despite giving 600 ml per hour. Then you have to give 20 ml per kg. So 20 ml is 1.2 liters per hour you have to give for a 60 kg. You have to give fluid boluses. If you do not give this, you are going to kill the patient by under resuscitating. And this is what we see in our ICU. And it saddens us to see that they are inadequately resuscitated most of the times in the ward, especially when they come very sick to ICU. This is something I want every clinician to bear in mind to resuscitate dengue adequately, because that is the only saving grace in these patients, and that is the only tools that we have to save patients. Again, here improvement, then you reduce to again 7 to 10 ml per kg for 1 to 2 hours. So please remember this algorithm. I think these algorithms every hospital should paste in every ward if you're dealing with dengue. And remember, it is 7 to 10 ml per kg. 10 ml for 60 kgs is 600 ml per hour. You have to give every hour and keep monitoring hematocrit. And hematocrit is coming down, you are going to reduce the fluid. If hematocrit goes up, you have to increase from 10 to 20 ml per kg, which is 1 liter. You have to give 1 liter boluses every hour you have to give. And only after that, then you will go back to weaning to 5 to 7, 3 to 5, 2 to 3. And you check hematocrit. And if there is overt bleeding, then obviously you have to give blood transfusion. There's no overt bleeding, then sometimes you have to move. If you have given a lot of fluid, still it is not improving, there is suggestion that you could consider using colloid also 10 to 20 ml per kg per hour, 10 to 20 ml. So which means you are giving starch at 1 liter per hour. So that's the volume you may have to give in these patients to save a life. So I request every listener to pay attention to this, more so non-intensive ways, because we see this every dengue season, patient coming to ICU under resuscitated. Only thing that they would have missed out is on adequate fluid resuscitation in the ward. So please remember this flow chart, and you can paste these flow charts. These are available in all the web resources. Is present on the WHO. Print out this and paste in the words. So remember, it has to be 10 to 20 ml to start off, and then you reduce it to 5 to 10 ml, then 5 to 7 ml, 3 to 5 ml, 2 to 3 ml. So this you have to keep resonating in your mind and give at that dose, which is, so at least if you can't remember all that, you have to remember it has to be minimum of 600 ml per hour or up to 1 liter per hour. You start off and then start reducing. Please remember this. So now look, last couple of slides on future directions. So people give steroids. So the studies, Cochrane database, all the studies have shown steroids are useless. There's no benefit of giving steroids in dengue. IVIG, this is a study from Philippines, again showing no benefit. And NOVA 7, factor 7A for bleeding, even that has shown to be of no benefit. And pentoxifylline, no benefit. So all these are futile. So especially steroids, need to emphasize there's no role for steroids in dengue. And the newer molecules, so they have used inhibitors of dengue antigen, NS antigens. So they've used all these molecules, 2B3 protease, 3 helicase, 5 methyl transferase, polymerase. So these are all experimental inhibitors of dengue antigens that they have used, which tends to inhibit the antigen load and modifies the the host and host viral response sort of a situation by using these. So these are all at experimental levels. So there are randomized controlled trials with these drugs. They have used chloroquine, lovastatin, balapiravir, and selgosivir. So balapiravir is a polymerase inhibitor. Selgosivir is an alpha glucosidase inhibitor. So all these randomized controlled trials have shown no benefit with regards to the fever in dengue or antigenemia or viremia. So the inhibitors of NS are at experimental level. So RCTs with these newer drugs have shown no benefit. So now coming to dengue vaccine. So when I was reading or preparing for this, so it fairly saddened me as to why India hasn't invested into dengue vaccine, because it holds a good promise. So right now there are two vaccines. So one is the dengue vaccine and the second one is TAG 003. So these are the two vaccines. There are good trials that have happened. And dengue vaccine is approved in 20 countries. So we know there are 4 serotypes of dengue virus, dengue 1, dengue 2, dengue 3, and these are all tetravalent vaccines. And dengue 3 and 4 prevalence is shown to be little low. And this vaccine is approved in 9 to 45 years of age. And all the listeners bear in mind, this vaccine is approved for patients with previous dengue infections. I will tell you what the reason is. So they should have had a previous dengue. And these are the patients for whom this dengue vaccine is approved. And there is a committee of immunization practices which belongs to CDC. So which has approved its usage of dengue vaccine 9 to 16 years, again with previous dengue. So this vaccine is not for patients who have not had a previous dengue or who are not seropositive. Okay. So there are two randomized controlled trials, one with dengue vaccine and one with TAG. So as you see, this randomized control trials was done in 5 countries. 2 to 14 years was one study, 9 to 16 years was one study. So 2 to 14 years study was published in Lancet in 2014. And the study was done from Philippines, Thailand, and Indonesia. 9 to 16 years came in NEGM in 2015, and this study was conducted in Latin America, all the South American countries, Honduras, Colombia, and so on and so forth. So here for dengue vaccine, they use 3 doses at 0 months, 0, 6 months, and 12 months. So it is a 3-dose regime of this vaccine. So the name of it is CYD TDV, that is the name. So the vaccine efficacy in these two studies, what they found was 57 to 61%. That was the efficacy. And the effectiveness lasted from 28 days to 13 months post that third dose. So post third dose, effectiveness lasted up to 3 months. Okay. And the highest effectiveness was in preventing dengue hemorrhagic fever. And it was successful in 80 to 95%. It prevented dengue hemorrhagic. So that is what we want. We want to reduce the morbidity and mortality. And it was shown to be very effective in preventing dengue hemorrhagic. And effectiveness against dengue 3 and 4 serotypes was 75%. Dengue 1, it was less 50%. Dengue 2, serotype, it was 35 to 42%. And 2 to 5 years, the effectiveness was much lesser. So this was the vaccine effectiveness of dengue vaccine. And in follow-up analysis, what they showed was if someone has had a previous exposure, this vaccine had a protective effect. But if someone has not had a previous dengue infection, in fact, it increased the risk of hospitalization and severe illness. So this was the paradox of this vaccine. It means if they have not had an infection, it can increase the risk of hospitalization and severe illness. And they did the subgroup analysis of seronegative patients, which means who have not had a dengue infection. Hospitalization, as you see in vaccine group, was 3% as compared to controls, which was 1. It means more patients needed hospitalization, and that was statistically significant. And patients who were seropositive, who have had dengue, when they gave vaccine, hospitalization was reduced to 0.75%, but in controls, it was 2.47%. Again, that was statistically, which means this vaccine was very effective in someone who's had an infection before. And it is shown in dengue, the subsequent infection is going to be more severe. Subsequent infection by different serotype is going to cause more severe infection and more life-threatening for patients. So it is to prevent that this vaccine was very effective. So listeners, that is the take-home message about this vaccine. But this is a beautiful vaccine. So this study was done in Latin America, which is the TAC 003. So phase 2 randomized control trial. So 1,400 patients it was done, and 48 months follow-up was done. And they used 2 doses 3 months apart, the TAC 1, which is produced by Takeda. So they did the study in 20,000 patients. So the first phase 2, this is a phase 2 randomized control trial to look at the dosage. This is the phase 3 randomized control trials, which was done in 20,000 patients, 4 to 16 years of age. And they did a 12-month follow-up. And they found that the dengue occurrence significantly reduced in a vaccinated group at 0.5 per 100% years, as opposed to placebo, where it was 2.5 per 100% years. Serious adverse events, there was no difference between the vaccine group and the placebo group. And the vaccine efficacy was 80.9%. So that was the vaccine. So it was more effectiveness. It was more efficacious than the dengue vaccine. And the good thing about it is this vaccine was fairly effective even in seronegative. So they looked at 5,200 patients in this 20,000 who did not have previous dengue, 28%. And even there, the vaccine had a good efficacy of 74.9%. But in this seronegative, we did not have any effect on dengue 3 and dengue 4. For data was insufficient for dengue 4. So this is a comparison between, see, there you saw in seropositive, it had a good effect, the dengue vaccine, but in seronegative, it increased the risk of hospitalization. But here, seropositive, the efficacy was 76.1%, and seronegative also, it was fairly good sort of effectiveness at 66.2%. In 18 months follow-up, for any disease severity, the vaccine efficacy was 73.3%, and its effectiveness against preventing hospitalization was 90.4%, which is very good. And so all in all, this vaccine is safe for seropositive and even seronegative, because in seronegative, this vaccine did not show increased risk of hospitalization, and it was found to be effective even in seronegative, which was not the case in dengue vaccine. So just to give a comparative analysis of dengue vaccine and tag. So dengue vaccine is 50% effective against dengue virus 1 serotype. TAC is 69.8. For dengue 2, it will be dengue vaccine was less, but TAC was more effective. Dengue 3, dengue vaccine was more effective at 75%, TAC was 48.9, and dengue 4, 75% for dengue vaccine and 51. So as you see, for 3 and 4, dengue vaccine was more effective. For 1 and 2, TAC seems to be more effective. Against 1 and 2 serotypes, TAC is more effective. Against 3 and 4 serotypes, dengue vaccine appeared to be more effective as per the current available data from these two last trials. So that's about vaccine. So when you read the literature about vaccine does hold a promise. And I still fail to understand why we haven't got this vaccine in India made available, especially the TAC vaccine. TAC 003 seems to hold promise because we have a huge morbidity and mortality in children and in adults with dengue. Uh, we should really work as a society to see why this vaccine is not made available in our country. So the summary is dengue has 4 serotypes, 1, 2, 3, 4, and we saw we have vaccines available against these 4 serotypes as tetravalent. And severe dengue is always caused by second dengue infection by another serotype. So that's why tetravalent vaccine has a role to play, because subsequent dengue infections can be lethal, and subsequent dengue by another variant can be life-threatening also in some of them, and we need vaccines to prevent that. And the quintessence of managing dengue is to identify the patients who are at the highest risk and try to pick up the warning signs which tell you that these patients are not going to do well. And we have to initiate prompt, aggressive treatment to prevent deaths in dengue. This is the crux of the whole dengue. If we fail to recognize the patient who has a warning signs and don't resuscitate them, then it's going to be a disaster for them. And no matter what efforts we put in ICU, we may not be able to save life if you have missed that golden period where adequate resuscitation measures should have been put in place. This one I have to re-emphasize because we see time and again under resuscitation many a times causes death in dengue. And especially patients who are admitted within hospital, they have to be assessed in a very diligent and vigilant way. I showed you that big table, how you have to carefully look at the blood pressure, you have to look at the heart rate, you have to look at urine output, you have to look at lactate, you have to look at capillary filling pressure, you have to look at the pulse volume, you have to look at hematocrit in a very vigilant way, assess for warning signs. If there is no capability of keeping a close vigil on these markers, please send to ICU, because under resuscitation is what kills them within the hospital. And please follow the protocolized therapy with fluids. So you have to start fluids at 5 to 7 ml per kg minimum. So which means at least start with 10 ml per kg, which comes to around 600 ml per hour. And if hematocrit don't improve, you have to increase to 20 ml per kg, which is 1 to 1.2 liters per hour, and then reduce it only if your hematocrit is showing trend towards getting better. Otherwise, you have no business to give fluids at 150 ml per hour, 250 ml per hour, 300 ml per hour. You have to give at minimum of 10 ml, then you reduce to 5 to 7 ml per kg, then 3 to 5 ml per kg, then 2 to 3 ml, and over 48 hours you got to wean and stop. And you have no business to reduce the fluids to 150, 200, 300, 400 for that matter. You have to at least remember 10 ml per kg. That is the bare minimum they need when hematocrit is sitting at high. And I still can't believe that we don't have vaccine. So I really need to look why we have not got vaccine, because we saw vaccine is a game changer in COVID. Even in dengue, I believe we have good vaccine, especially TAG 003 appears to be very sort of a good solution, at least from the data that is available. If we do not have a wherewithal to find out someone is seropositive or seronegative, at least just give TAC vaccine. It has at least 60 to 75% efficacy, either it is seropositive or seronegative, and it is safe for even seronegative patients also, unlike the dengue vaccine, which increases the risk of hospitalization or severe illness. So Thank you very much. Hope I've driven home the key salient aspects in dengue and what we can do to save lives. So end with this beautiful quote. So everyone thinks of changing the world, but no one thinks of changing himself. I think this is very prudent in dengue that one needs to change oneself to save lives, especially with regards to following a protocolized algorithms with regards to fluid resuscitation. So if that I'm able to percolate to the audience, I have done justice. So thank you one and all. So visit my website www.drpradeepramgap.com to rehear to this if you have any to gain clarity and insights. So thank you one and all.